Hello, everybody. Hope that you're doing well. We'll recap what we had gone over yesterday in class. Yesterday, we covered pulmonary perfusion, uh, blood flow through the lungs. We also talked about blood flow through the heart as well. So it's important to make sure that we have an appreciation uh, for blood flow through the heart. You've got to remember blood flow through the heart, starting from the right to the left. We know that the right side of the heart receives deoxygenated blood from the body, and then it's going to move blood forward into pulmonary circulation. Gas exchange is going to take place in pulmonary circulation, the exchange of oxygen, exchange of carbon dioxide. Then that newly oxygen rich blood is going to be sent back to the heart by way of the pulmonary veins, and then into the left atrium, through the left ventricle, up into the aorta, and then out to the rest of the body. So the heart's sole purpose is to move blood forward, and we can break down the heart into the right and the left side uh, uh, of the heart, or the pulmonary side and the systemic side. So we do have two different circulatory systems, if you will, within our, but we have a pulmonary circulation and we have a systemic circulation. Pulmonary circulation is the blood flow through the lungs, while the systemic circulation is blood flow out to the rest of the body. Keep in mind, in systemic circulation, the arterial system is going to carry oxygenated blood while the venous system carries deoxygenated blood. It is the opposite in pulmonary circulation. So in pulmonary circulation, the pulmonary artery or arteries will carry deoxygenated blood, while the pulmonary vein is going to carry oxygenated blood back to the heart. So we had mentioned earlier the right side of the heart receives its blood supply from the body and pumps its blood that it receives into the lungs. The left side of the heart receives its blood supply from the lungs and pumps its blood out to the body. So deoxygenated blood returns to the right side of the heart while oxygenated blood leaves the left side of the heart. And the whole oxygenation process happens right there within the lungs. I found this illustration online, and it's pretty interesting to look at, and it explains it quite well. I did get it off of this website that you see down here, so kudos to them for having a fantastic illustration to share with. But nonetheless, in reviewing what we had talked about, so that we understand that if we're looking at this page, that this is the right side over here, while this is the left side. So when I mention the right side, so if it's the right lung, it's over here. If it's the right ventricle, right atrium, we're over on this side. If it's the left side, we're going to talk about everything on this side of the screen. Remember that your pulmonary circuit is a relatively low resistance system in comparison to that of the systemic circuit. So, right side of the heart is under a significant amount, the left side of the heart is under a significant amount of pressure, as opposed to where the right side of the heart should not have to work terribly hard. We also talked about the inclusion of a pulmonary artery catheter. That pulmonary artery catheter may be referenced as a balloon tip flow directed catheter. Um, the proprietary name for that is the Swan-Ganz catheter. And you may see it on exam items as such, but I would be on the lookout for pulmonary artery catheter or uh, balloon tip flow directed catheter. Important to note, for the purpose of what you might be asked moving forward, that we're going to be concerned with our proximal port and the distal port of that pulmonary artery catheter, the Swan-Ganz catheter, or the balloon tip flow directed catheter. Don't want to be terribly redundant, but those things are important because you're gonna see them in test question or test items. So the proximal port, you can deliver medications, but as far as hemodynamics or give fluids and so forth, but as far as hemodynamic values, that proximal port is going to stop at the right atrium, and it's going to measure your right atrial pressure, your RAP. Right atrial pressure is also going to be indicative of what our CVP is, central venous pressure. So the two of those relatively synonymous terms, they have the same values depending upon the textbook that you look at, but you probably look at around 0 to 6 millimeters of mercury for that. and can be indicative of their overall fluid status, can be indicative of how things are going on the right side of the heart, uh, can give us a measurement to an extent of the preload. So if we look at preload and we look at afterload, preload is essentially the amount of stretch on the heart before contraction because it represents the volume of blood that's returned to the heart prior to contraction. Afterload is the resistance against which the heart has to pump. So if we're looking at afterload as the resistance against which the heart has to pump, most of your textbooks and everything are going to basically reference afterload to the left side of the heart. But I want us to understand that you do have things that can increase afterload on the right side of the heart. You've got things that can increase afterload on the left side of the heart, and conversely, that thing afterload can be decreased as well. But if we look at afterload in of itself as resistance, pulmonary artery pressure or pulmonary vascular resistance uh, is the afterload for the right side of the heart or your right ventricle. Now, keep in mind, we can have mechanical structures too that can have an impact on afterload. So, for instance, if I were to have uh, a stenotic pulmonary valve or a pulmonic semilunar valve, it would make sense that if it's not as compliant, it doesn't move as well as it once did, then that's going to generate some back pressure, and the right ventricle is now going to have to work harder to pump blood through that pulmonary circuit. If we were to have pulmonary hypertension, the blood vessels within the lungs tighten down. You get vasoconstriction there. It is possible that that's going to increase the workload of the right ventricle, and because of an increase in PVR. PVR is your pulmonary vascular resistance. So we also talked about that yesterday. We also talked about the calculation of that and the importance of making sure you utilize that numerator and denominator and then multiply your answer by 80 so that you can convert from the Woods unit to the dynes per second to the per centimeter to the negative fifth power unit of measurement that you'll likely see that reported in. And we also compared SVR and PVR, and you saw that the value for PVR was significantly less than that of systemic vascular resistance. But vessel tone can have an impact on right ventricular afterload. That stenotic valve can have an impact on right ventricular afterload. If we talk about afterload to the atria, a stenotic tricuspid valve could cause an issue there. So if you're beginning to have a stenotic valve and the right atrium is having a little bit more difficult time moving blood through the right ventricle, it would make sense that we might see an elevated CVP or RAP. Uh, Also, it would make sense that if we have a failing right heart, whether it's due to mechanical failure or an increase in afterload downstream from the right ventricle, that we would begin to see those clinical signs and symptoms such as the jugular venous distension that we might see. You might, upon palpation, be able to feel hepatomegaly or that enlarged liver. You may, on appearance, see that individuals have swollen extremities, where we're talking about the pedal edema or things of that nature. So it's important. We've got to make sure that we have an appreciation for that. On the left side of the heart, so our systemic blood pressure under normal circumstances, probably in the ballpark of about 120 over 80, with 120 being the systolic number, 80 being the diastolic number. Vascular tone, fluid volume, things along those lines are going to have a direct impact on what your SVR is. And I remember SVR, your systemic vascular resistance, is a direct indicator of the workload of the left side heart. So if SVR goes up, the left heart's got to work quite a bit harder. The left ventricle's got to work harder. But again, there you can have mechanical issues as well. Let's say you've got a stenotic aortic valve or aortic semilunar valve. Uh, that's going to make the left ventricle have to work harder. Under normal circumstances, the left heart has to work harder than the right side of the heart because naturally, the left side, the systemic circuit generates more afterload than the vascular of the lungs do under normal circumstances. And if you think about it, it makes sense because if the right side of the heart just has to pump its blood right here to the lungs, and the heart or the left side of the heart is responsible for pumping blood out to the rest of the body, hopefully that makes pretty decent sense. Another thing that we mentioned yesterday with measuring or monitoring these hemodynamic values, yes, if I want to assess someone's blood pressure, I'm going to take a sphygmomanometer or a blood pressure cuff. I'll apply that and have them hold their hand level. You'll go through the process of pumping that cuff up and uh, you can listen for an auscultatory gap if you've got it there. But nonetheless, you'll go through the appropriate means of assessing your blood pressure with stethoscope and sphygmomanometer, all the while watching the manometer and listening with your ears for those changes from your systolic to your diastolic number. If I want to know what somebody's blood pressure is, I can place a blood pressure cuff on them or a sphygmomanometer on them and check it. If I want to know what somebody's pulmonary artery pressure is, I can't wrap a sphygmomanometer around their pulmonary vessels and determine what that is. So that's going to take the placement of a pulmonary artery catheter or a PAC. That pulmonary artery catheter that we talked about yesterday, remember your book talked about it being the Swan-Ganz catheter. That's a proprietary name. So I would make sure that in anything that we study for respiratory, if there's more than one way to refer to that as, I would make sure that I put that on a study card, whatever, to make sure that I can know however many things it is to call. And I'm going to talk about some of that here in just a moment when we get a little bit further. That so with the Swan-Ganz catheter, your pulmonary artery catheter, the PAC, you might even see it mentioned as a balloon tip flow directed catheter or the flow directed catheter uh, balloon tip catheter. With that, some things that we need to make sure that we understand is you can measure cardiac output. Now, generically, heart rate times stroke volume gives you cardiac output, but you can also do thermodilution to monitor and measure your cardiac output. You'll learn a little bit later in the semester how to calculate your cardiac output utilizing the Fick equation, which requires you to know a few other formulas as well. We did talk about the calculation of PVR, pulmonary vascular resistance. We've also talked about the calculation of SVR. So you'll need to make sure that you can remember those moving forward. And we did talk about the importance of multiplying the numerator and denominator once you get that answer by 80 for the conversion to the more appropriate or the more commonly used unit of measurement for SVR and PVR. So when we place this pulmonary artery catheter, it can be through the jugular vein or through the subclavian vein. Obviously, after placement, you're going to be concerned with the potential for a pneumothorax, or you'd assess for a chest X-ray after that gets placed. But I'm going to try to draw, so I'll use the color yellow, and I'll try to thicken that up a little bit so that it shows a little better on screen. But nonetheless, that catheter is going to come through the right atrium. And once we get to this point, that you might even see that balloon tip flow directed catheter, they may inflate the balloon so that it can utilize blood flow to facilitate moving this catheter through the heart. So we'll go through the tricuspid valve, we'll get up into the pulmonic semilunar valve, and then hopefully that catheter is going to make it, it can go to the left branch, the right branch, to the left branch or the right branch, and that catheter will essentially rest in that pulmonary artery. Uh, so talking about the catheter and up here as it goes through, if it's by way of insertion through the jugular vein, when the patient is lying in the hospital, you'll see they'll probably have a piece of tegaderm over their skin, and you'll have a few different items hanging from it or accessible. So it's the different ports. So if you're looking at a multiple lumen catheter, as in this pulmonary artery catheter is, if we were to look at a cross section of it, if it's triple lumen, quadruple lumen, double lumen, if it's a triple lumen, you'll have three other lumens inside of it. And ultimately, each of those items will terminate at various points. So one of those is going to be your proximal port. The other will be the distal port. And those are two that we'll kind of need to concern ourselves with a little bit. The proximal port, you're looking at uh, fluid administration, things along those lines, but that's also uh, where we can tend to look at the measurement of our RAP or CVP that we had talked about already. The other port that we're going to be concerned with, especially if you're asked to draw a mixed venous blood gas, a true mixed venous blood gas, that true mixed venous blood gas will be pulled off of the distal port of the pulmonary artery catheter because that distal section, and remember, proximal is closest to distal is going to be further away. So you got to remember your terminology that rests within the pulmonary artery. So that's going to give you the best sample of a truly mixed venous gas that you can have much better and much more reliable for the purposes of hemodynamic calculations than if you were to draw like a VBG out of a peripheral vein or something of that nature. Uh, so with that being said, draw mixed venous gas off of the distal port, but also we've got to make sure that we pay attention uh, to the waveforms associated with that pulmonary artery catheter because you should be able to determine by looking at the waveform tracing where that pulmonary artery catheter is. And if you can remember to flow through the heart, that catheter's got to follow flow through the heart. So it's going to go right atrium, right ventricle, pulmonary artery. And then when we're looking at that pulmonary artery catheter tracing, there's another thing that we'll look at, and that is I'll change colors once more, and that'll be back to our we'll look at our PCWP, your pulmonary capillary wedge pressure. So we'll also, I told you if there's a few different ways to know something, we should probably know those different ways. So I told you yesterday, you can look at that as PAOP, pulmonary artery occlusion pressure, or PAWP, pulmonary artery wedge pressure. All three of those while they're three different abbreviations, they all mean the same thing. Uh, so you'll want to keep that in mind. And typically we utilize a reference range in a ballpark of 4 to 12 millimeters mercury for that. Uh, and also alluded to the fact when we start to talk about pulmonary edema. Remember, if you think about pathophysiology, you get those pink frothy secretions. That's pretty much the hallmark of pulmonary edema. And that pulmonary edema can be by means of, it can be cardiogenic in nature or non-cardiogenic. If you're trying to determine cardiogenic pulmonary edema, that would mean that you've got issues originating within the heart or maybe the heart and heart failure to an extent. But we begin to look at an elevated pulmonary capillary wedge pressure, pulmonary artery occlusion pressure, or pulmonary artery wedge pressure, and sometimes it can be well above 20 if you're looking at a cardiogenic pulmonary edema issue. We also talked, and I know I'm trying not to be terribly long, but we also talked about the differences between our oncotic pressure, our hydrostatic pressure, the difference in having an appropriate uh, gradient and an appropriate mixture of that pulling pressure, that pushing, or the hydrostatic pressure being your pushing pressure, the oncotic pressure being the pulling pressure, if you will, and having an appropriate balance between those pressures so that fluid stays within that capillary network as opposed to actually moving into the lungs. And under the case of pulmonary edema, we've got fluid that does make it into the alveoli. And then to counter what we had talked about leading up to that, we talked about shunt and dead space. So remember, if you have a dead space unit, you have ventilation without perfusion. If you have shunt, you have perfusion without ventilation. So a pneumonia, atelectasis, consolidation, fluid-filled alveoli, going to be a situation where the capillary network is still receiving perfusion and blood flow through that area, but that alveolus is not being ventilated. So you have perfusion without ventilation, which is shunt. And when you have shunt, you essentially have deoxygenated blood mixing with oxygenated blood that is going to lower the O2 amount or the oxygen amount of that blood that's ready to be sent back out to the body or into systemic circulation. Uh, Now, if you have a situation in which, let's say, you have an alveolar unit, and you've got your capillary, your blood flow going past. Now, I know that it encompasses that, but for the purpose of illustration, we'll see. And let's say that we have a blood clot or a pulmonary embolism now, and let's say that the direction of blood flow should be moving that way. So if this blood clot or pulmonary embolism blocks blood flow to that alveolar unit, now this alveolar unit will receive its ventilation, but it's not receiving perfusion. So there we see ventilation without perfusion. That's a dead space unit. And we really want to try to prevent that from happening as we can. We want to try to prevent the shunt from happening as well. We also talked about we do have a certain degree of normal anatomical shunt. We talked about um, the anastomosis that can. We also talked about the bronchial blood flow and how naturally there will be some mixing of deoxygenated blood with that oxygenated blood. When you get to your neonatal class, we'll talk about the whole, if you have a patient has a PFO between the atria, or if they've got a PDA, a patent ductus arteriosus, we'll talk about certain things, or if it happens to be an ASD, atrial septal defect, or a VSD. But this isn't about pathophysiology to an extent in this regard. We're talking about pulmonary blood flow, pulmonary perfusion. We also mentioned yesterday the hypoxic pulmonary vasoconstriction that can come about. If you happen to have a true um, uh, decrease in the alveolar PO2. So that's going to be a concept that you're going to want to make sure that you can remember. And I know that I'm trying to keep this relatively short and I'm getting a little on the lengthy side now, but there's a massive amount to talk about. I mean, that's why it took us 3 hours to get through it yesterday. And then we had ventilation to talk about dead space and so forth. And we'll just follow up with the dead space issue. We talked about anatomical dead space. We talked about the potential for alveolar dead space. When you combine the anatomical dead space and the alveolar dead space, you have your physiologic dead space. I also mentioned to you that not to be terribly concerned right now, but later on down the road when we get into mechanical ventilation, you can actually have mechanical dead space that gets added. Anything that you place between the the Y of the ventilator circuit, which I explained yesterday, in the patient is essentially going to be added or extra mechanical dead space. So we'll talk about that in a different setting or later on when we get to mechanical ventilation. But it is important to understand that if I breathe in a 500 cc tidal volume, that based upon the anatomy of my respiratory system, remember you've got your nasopharynx, the oropharynx, pharynx, trachea, bifurcation of that trachea in the left and right main stem bronchus, and then continuous dichotomy all the way to get down to those terminal bronchus, all the way to the level of the acinus where the alveoli are at. So if I take in a breath and I measure that at 500 cc's or 500 milliliters, we have to understand that not all 500 of those milliliters or 500 of those cubic centimeters make it to the alveoli. So I also want to stress upon you that we've said that the only effective ventilation is alveolar ventilation. So we take into account that anatomical dead space, to an extent, the alveolar dead space, you can add it all up. But with anatomical dead space, so let's assume that my anatomical dead space 150 milliliters. So if I took in a 500 cc tidal volume breath and 150 cc's of that is anatomical dead space, then that would essentially mean that roughly 350 cc's made it to the alveoli, and that is the effective portion of the tidal volume that I took in because that got down to the alveoli. So yes, minute ventilation is respiratory rate times tidal volume, but we need to be concerned with the alveolar ventilation is. So it would be respiratory rate times your alveolar volume. So to figure that out, you take your tidal volume, figure out what your dead space volume is. You subtract your dead space volume from that tidal volume, and then multiply that by your respiratory rate to get your alveolar ventilation. We also talked about the abbreviations. So remember, if you're talking about a flow or a minute ventilation, it'll be a V with a dot over it. If it's a V by itself, then that's an individual volume. So we want to make sure that we remember that stuff as well. Um, and you're going to have a cardiopulmonary case study to work on here in the next little bit that I'll give out that you'll be able to utilize all of these hemodynamic calculations that we've gone into. It's a little bit of a murder mystery, so hopefully you'll be able to figure out who did it, and that'll be a good time. So just a brief, quick and dirty overview of what we covered in class yesterday, and I hope that you find it helpful. Try to utilize terminology that you are going to see in the hospital, but also terminology that you might see on exams too as we go through there. Thank you all for your time and attention. I hope you have a good day.